Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Standard Medical Notes. So let's continue the topic of fever. Moving on to the topic. Let's begin with the name of Allah. So whenever you document fever, so yesterday I described when you should consider it as fever. So if you are measuring with orally and using mercury or digital thermometer, okay, then uh, more than 37.8 degrees Celsius or more than 99.9 degree Fahrenheit PM temperature is considered as fever. Or if you are using infrared thermometer then more than 37.4 degrees Celsius PM or more than 98.9 degree Fahrenheit PM temperature is called as fever. Okay, now fever sorry so fever versus hyperthermia versus hyperpyrexia, we need to distinguish when we document fever. Distinguish fever from hyperthermia is important because the treatments are diametrically opposing. Antibiotics which work by lowering the hypothalamic set point are effective for a fever but useless for hyperthermia, where the set point is already normal. So that's why having difference is important. And one important point to differentiate is fever will be usually between 38 degree 38 degrees Celsius to 39.9, I can say. Okay, and hyperthermia will be hyperpyrexia will take, it will be usually between 40 to 41 degree 1 degree centigrade, and whereas hyperthermia will be more than 41 degrees centigrade. So some variations are there. Some books say more than 41.5 degrees centigrade as it is given here. So I am taking a conservative value more than 41. So 40 to 41 think as hyperpyrexia, more than 41 things as hyperthermia, 38 degrees centigrade to 39.9 degrees centigrade considered as fever. So that's how you differentiate based on measuring the fever with thermometer. Okay, so in this table just remember these things. So pathophysiology, what to remember here, the hypothalamic set point is raised, where and same is for hyperpyrexia, the set point is raised here, but in hypothermia set point is normal. That's why antipyretics will not be effective in this case. What are the causes for these? For fever, you remember it as infection, inflammation, malignancy, and autoimmune disorders. So these four are the meaning the etiology of fever, as we have discussed, non-infectious and infectious. Whereas for hyperthermia, heat stroke, either it can be classic heat stroke or exertional heat stroke. So the difference between classical and exertional is, in classic heat stroke, the managing mechanisms of the body are impaired because of some patient cause. For example, in alcoholics, those patients who drink a lot, who take a lot of alcohol, and they are exposed to a very high grade temperature, for example in summer season, so if they don't do exertion also, they will have heat stroke because the central mechanisms are impaired in them. Okay, whereas exertional heat stroke anyone can experience who is working in a high environment. Okay, that's the difference. That is one very classical example. Heat stroke can be classical or exertional. Second example is drug induced, like serotonin syndrome, patients who are taking tricyclic antidepressants, or SSRIs, selective serotonin reuptake inhibitors, or SNRIs. Okay, so all these patients can experience serotonin syndrome if you give some other drugs which also increases the level of serotonin in the patient's body. Other thing is, so this drug induced. One example classically is serotonin syndrome. Second example is neuroleptic malignant syndrome. Third cause is the metabolic cause. Metabolic cause classically you can see in thyrotoxicosis, where the metabolic activity of the cells of the body is increased. So when the metabolic activity is increased, there is a lot of generation of heat, in the body. So patient with thyrotoxicosis, meaning increased thyroid hormone levels in the body, may have hyperthermia because of this thyrotoxicosis, also known as thyroid storm. Temperature will be raised very much. Okay, because the basal metabolic rate is increased in these patients. So these are the three examples of hyperthermia: 1, 2, and 3: heat stroke, drug induced, and metabolic cause like thyrotoxicosis. So these causes you should remember. Hyperpyrexia you can see in classically in severe infections like sepsis, okay, or CNS hemorrhages. These two are important causes. And CNS hemorrhages like hypothalamic stroke patients, because hypothalamus manages temperature regulation. So any vascular condition like hemorrhage or ischemia to that region may have hypothalamic stroke like pattern, okay. So CNS hemorrhages or severe infections, hyperpyrexia can occur, okay. So causes you should remember, mediators already you know. So how do you now how do you treat these patients? So when you know the mechanisms, easy to treat. So if fever will respond to antibiotics, paracetamol and NSAIDs. But this hyperthermia will not respond to antibiotics because the hypothalamic set point is normal. So this requires physical cooling. What you will do, you will unclothe the patient, undress the patient fully, and you just dip the patient in lukewarm water or some cold water. Okay, not very much cold, but just dip the patient in water. That is one thing. Another thing is expose the body and spray on the body lukewarm water along with cooling with the fan, cool with the fan, and spray lukewarm water on the patient. That will cause evaporative cooling and that will reduce the temperature of the patient. And some other methods are like keeping the ice packs in the axilla, in the groin, okay, below the chin. And these all methods are used for this hyperthermic patient, or okay. So that's the treatment here. Now in hyperpyrexia, the temperature is very much, but hypothalamic, because it is a severe form of fever, that's why you should use both the things. You should use both antipyretics as well as physical cooling in these patients to prevent cellular injury, okay. In hyperpyrexia you should use both antipyretics as well as physical cooling. So that's the treatment that you should remember. So what are the skin findings? That is how we decide with the temperature, okay. Now what the skin findings? Skin findings in fever, as we know, there are three phases. There is a cold phase, there is a chill phase, nothing but chill phase, when the skin is cold and clammy, and then there will be a maintenance phase, then there will be defervescence phase when you give antibiotics. Whereas this is more important in hyperpyrexia and hyperthermia. In hyperthermia patients, the skin is typically hot and dry, so it is not diaphoretic. Usually it is not diaphoretic unless the patient is experiencing exertional heat stroke. Then the skin will be diaphoretic, meaning it will be wet. Otherwise it is hot and dry in classical heat stroke, whereas it is profusely diaphoretic in exertional heat stroke, okay. Because hyperpyrexia is a severe form of fever, that's why the skin will be flushed here, and it will be hot, flushed skin. Patient will be uh, looking very red, okay. So that is flushed, and it is hot due to extreme elevation of temperature. There is vasodilation. Because of vasodilation, so there will be flushing, redness of the skin along with hot skin. Here hot and dry skin, okay. So these are the skin findings you see in patients. So again, here temperature is given. Here fever rarely exceeds 41.5 degrees Celsius, 106.7 degree. Okay. Here hyperthermia can exceed 41.5 degree, but usually we consider when it is more than 141 degrees Celsius, according to Davidson, it is considered as hyperthermia. And here hyperpyrexia he gave it as 41.5 degrees Celsius, but in Davidson it is given it as more than 40. You consider it as hyperpyrexia. More than 40. Conservative value is 40. I think 40 is good. Okay. 40 is good. Okay. That's about these things you should remember while you document high temperature. What are the things? So pathophysiology, you know. Causes you should know. Causes of each of the thing are different. Temperature variations of each of the thing are different, and skin findings of each of the thing is different, and response to treatment of each is different. Okay, that's about in detail. So once you have documented fever, you should differentiate whether it is hyperthermia. Based upon temperature, you check, you will get an idea, or it is hyperpyrexia, or it is fever. Okay. Now we will come over. Now you have documented the fever. Now you will assess the patient with fever. Clinical assessment of a febrile patient. The evaluation of a patient with fever. The evaluation of a patient with fever requires a Sherlockian approach. What is Sherlockian approach? Actually, Sherlockian is a Sherlock is a name of what do you call name of a fictional detective. Fictional detective. Fictional detective. So we should act as a detective. We should not miss any minor point. Okay, we should take each and every point. We should collaborate. We should collaborate those findings, and we should and what and based upon that collaboration, based upon that findings, we should narrow our diagnosis. That is the Sherlockian approach. Okay, detective approach. So it is a fictional. Sherlock is a name of a fictional detective. Okay, so that is why Sherlockian approach should be used. So based upon findings, you will narrow your diagnosis. Then investigations will be according to those findings. Then the cause will be find out, and then you treat according to the cause. That's how that Sherlockian approach works. So fever is a non-specific sign that accompanies hundreds of disease processes. The goal of the clinician is to identify localizing signs that narrow the differential diagnosis from fever to a specific syndrome, like fever with meningismus or fever with right upper quadrant pain. Okay, so this is Sherlockian approach. So you find findings based upon fever with findings, you will narrow your diagnosis. Now, to localize infection, okay, just remember how you will follow the Sherlockian approach. You documented the patient is in fever now. We will discuss. We are discussing fever. So whenever you encounter a patient with fever, okay, whenever you encounter a patient with fever, the first thing what we should do is this initial triage. This thing. The first thing is this. What is this thing? I will say. We should assess the stability of the patient first. Whether the patient is stable. Number one thing. Number two thing. Whether we should assess the red flags. Whether the patient which is having fever, whether he has red flags or whether he is in high risk. What is that we'll discuss. And then third thing is severity. Whether the patient is severe in infection. The patient has severe infection. So these three things first we should uh, ask to ourselves. So whether the patient is stable or not, whether the patient has red flags or not, whether the patient is high severity. Okay, because if the patient is unstable, or if the patient has red flags, or if the patient has high severity, then you need to manage the patient in ICU. ICU, you should manage the patient. Immediately admit the patient and manage the patient in inpatient department, as inpatient department. Either it can be in the general ward or it can be in ICU care. That's why we should exclude these things. So this flowchart guides that thing. So documented the fever. Now patient presents with fever. Hot to touch. Hot to touch. How to touch? You will touch with the back of your this palm. Okay, on the forehead typically. Hot to touch. So immediately assess airway, breathing, circulation. Disability is nothing but mental status of the patient, and exposure. Nothing but temperature assessment. Okay. So if the patient is unstable, meaning if the saturation is falling, or the patient has hypotension, or acidosis is there, or patient GCS is low, or the sensorium is altered, okay, exposure, if the temperature is very much high, like hyperpyrexia is patient is having, so then that the patient is considered unstable, and that patient requires a critical resuscitation area, active sepsis and trauma team, and immediate intervention is required. What you will do that in immediate intervention? You will give broad spectrum antibiotics. Okay, before giving antibiotics and IV fluids and vasopressors if required, you will send blood investigations, normal lab investigation like CBC, CRP, ESR, peripheral smear for malaria or other parasite, and creatinine, electrolytes, these things, and procalcitonin levels, and if required, then blood culture, urine culture, all these you will send. Then you will give broad spectrum antibiotics. Then after 2 to 3 days, specific treatment you will give according to your treatment reports. Okay, so that antibiotic will be upon the syndrome which you establish by taking history and examination. Okay, that syndromic management of fever is another topic, meaning I will be discussing that topic as a continuation of this topic, but it will come later. Okay, and it is very interesting. Okay, just to discuss here is when the patient is unstable, or when the patient has red flags, or if the patient has severe infection, you will proceed like this treatment which I have discussed just now. Okay, so patient is unstable, so immediate treatment is required, immediate admission and treatment. So what is the red flag and high risk assessment? So immediately see whether there is a non-blanching rash. Non-blanching rash or petechial rash or purpuric rash indicate most probably it can be a meningococcal infection, so sepsis. Okay, so that patient should be admitted. Non-blanching rash is a red flag. Whether the patient is immunocompromised or chemotherapy, like HIV patients or patient on immunosuppressants, okay, then also the patient should be taken inpatient. Whether patient has severe localized pain or rigors. I said no. What is rigor? Rigor is severe skeletal muscle contraction typically described as shattering of teeth. The patient will be chipping his teeth, and you can hear the teeth shattering. So the teeth shattering, remember the word teeth shattering is present. That is a feature of Rigors. Okay, if the patient Rigors, probably he is having sepsis. So that's why inpatient treatment is required. Whether the patient has recent surgery or indwelling catheter, whether the patient has altered mental status, confusion, again D, disability. Okay, travel history or high risk exposure, meaning the patient has exposed to a patient, for example, in COVID-19 patients. So any patient who is exposed to that index case will be monitored, no, like that, high risk exposure, or high risk exposure like sexually transmitted infections. Okay, those also come under high risk exposure. So these 6 things you remember. So these are considered as red flags in a patient with fever. What is that? Non-blanching rash, and you remember as first signs and symptoms will take. So non-blanching rash or Rigors, okay, or altered mental status. Brash, Rigors, rash, Rigors, and altered mental status. That is one thing. And in history, immunocompromised, recent surgery or indwelling catheter, travel history or high risk exposure, like those who work, those who do sexual work, all those, okay, or those who are engaged in unprotected sex. All those things are considered as high risk exposure. Okay, those patients are also considered as red flags. So just to think, so there are 3 things from history, 3 things from signs and symptoms. 3 things from history is one is I will just rub it just to say. So the red flags are 6. One is 3 history, immunocompromised. So diabetes mellitus patients who are uncontrolled diabetics also come into this category of immunocompromised state, and recent surgery or indwelling catheter, or travel history or high risk exposure. Okay, so immunocompromised state, travel history or high risk exposure, or recent surgery and indwelling catheter. Other thing is Rigors, okay, non-blanching rash, and altered mental status, skin, CNS, and skeletal muscle. Skin, CNS, and skeletal muscle. Okay, so these are the 6 red flags of fever. Now, how do you assess the severity? So if the patient is stable, okay, patient is stable. Now you will see whether red flag or high risk assessment. High risk assessment, nothing but those who are involved in high risk occupation, or some healthcare workers which are working in tuberculosis department or HIV department, biohazard department. So those persons are considered as high risk. Okay, so now patient doesn't have red flags also, no red flags are present, then you should ask the third question, whether the patient has high risk severity. So how you will assess high risk? So there are 2 methods. So one was discussed yesterday, that was about SARS, severe sepsis, and septic shock. If the patient has severe sepsis, or if the patient has is in septic shock, then it is considered as severe infection. Or some books see these things, and the updated guidelines are these, which say that these scores or vital signs should be used to adjust the severity. So Q's of a score, it consists of 3 things: respiratory rate, the consciousness, and systolic blood pressure. Sorry, it is actually less than 100. Okay, so if the respiratory rate is more than 22, don't take it as 22 or 22 or 24 you can take. If the respiratory is more than 22, or patient is altered mental, confusion, delirium, or decreased GCS, SBP is less than 100 or 90, you can take. Okay, less than 100. So if equal to or more than 2 scores are present, then that patient is considered as high risk. Actually this is less than 100. Okay, less than 100. Or you will see vital signs. If heart rate is more than 130 beats per minute for the fever, that is high risk. Respiratory rate more than 25 beats, 25 per minute, or 24 per minute you can take. Saturation is falling, less than 94 only is a not good sign. Okay, it is less than, so saturation is less than 91% at room air, or if the temperature is less than 36 or more than 38.5, temperature less than 36 or more than 38.5, so these vital signs will give that means the patient is in severe infection. Now lactate levels are other thing. More than 2 millimole per liter indicate hyperperfusion, that means the patient is in sepsis. Okay, not in septic shock, you can say patient is in hypoperfusion. More than 4 millimole per liter of lactate level is considered as septic shock. So that is again you should manage in ICU. So these things you can use: Q-SOFA score, respiratory rate, BP, and your mental state. So more than 2 or equal to severe infection. Vital signs: heart rate more than 130, respiratory rate more than 24 beat per minute, saturation less than 91%, fever more than 38.5 or less than 36 degrees Celsius, or lactate level more than 4 millimole per liter. So that is considered high risk. Now, nothing is there. All of the patient is not severe. Patient does not have any red flag. Okay, and the patient is not unstable. Not unstable. So if nothing is there, then what you will do, if the uh, patient is less than the duration of fever is less than 4 days, then what you will do, you will take a focused history and examination. You will monitor the vital signs. You give symptomatic treatment. What is that? Paracetamol. Paracetamol plus fluids you will give. When you will give just paracetamol fluids when there are no localizing signs, or if the fever is considered as viral for less than 4 days. This is according to Merck's Manual of Medicine. Merck's Manual of Medicine. Okay, and if the fever subsides within 4 days, then discharge the patient. And if it is more than 4 days, then we'll discuss it later. Okay, just this flowchart is just to triage the patient coming with fever. Okay, triage the patient who are coming with fever. So as I discussed, no, if the patient is in a severe infection or with red flags or with unstable, then you should take immediate action with this is known as sepsis bundle. IV excess blood should be taken for lactate blood culture. Start empiric IV antibiotics, IV fluids if indicated, and senior clinician review. Okay, so this is initial triage of the patients with fever. 3 important things I discussed. Okay, now if the patient is not unstable, if the patient is not having any red flags, if the patient is not having severe infection, then you will take your own time and take a precise history and do a proper clinical examination, and then according to that you will send investigations if required. Okay, so history taking in infectious disease must be exhaustive. The clinician must systematically interrogate the patient. Now in history, what you should focus? So our main goal is to club the history and physical examination findings and find out the etiology. That is our main goal. So in history, what you will ask particularly, so duration of fever is very important, one thing. Okay, second is exposure history is very important. Third is any localizing signs or symptoms is very important. These things are very, very important in a case of fever. Just I will revise. So duration of fever is very much important. Duration of fever, since when the fever is lasting. Number 2 is exposure history is important. What exposure we will discuss. And number 3 is any signs and symptoms. Symptoms and signs. Okay, symptoms and signs. So these 3 are very, very important to make a provisional diagnosis. Provisional diagnosis. This duration of fever, exposure history, and symptoms and signs, which is the patient having. Along with fever, what are the symptoms and signs? Okay. Okay. Now let us discuss about the first thing. So we have documented the first thing we have done that. Okay. First thing, what is that? We have documented. Fever, documented the fever. So patient who are having a subjective feeling of having fever is unreliable. You should document entry criterion is more than 30 degrees centigrade, or it is, you can take 37.8 degrees centigrade also. In Fahrenheit is 99.9 degree Fahrenheit. Okay, so that is documented. The patient is having fever. Now, what is the duration? This is the most important thing. Okay, most potent discriminator. Okay, so it is classified as acute if it is less than 1 week. Now, for acute, subacute, chronic, the causes are totally different. That's why this classification is very, very important. If it is subacute, it is if it is lasting from 1 to 3 weeks, then it is called as subacute. Chronic is more than 3 weeks. Chronic is more than 3 weeks. Remember, acute, subacute, and chronic. Now, if it is less than 1 week, then the causes are usually viral respiratory infections. Okay, or it can be bacterial respiratory pneumonia, malaria, dengue, urinary tract infection, or GI infections also you can take. So these are the common causes in less than 1 week. So viral infections of the respiratory tract or bacterial infection, bacterial pneumonia, malaria and dengue. So mosquito, you see the mosquito and remember the cause. And lungs is nothing but pneumonia, bacterial pneumonia, and UTI, urinary tract infection. So less than 1 week fever, you should consider one thing. And one more thing to add here is gastral infection. So these are the common infections you encounter in a patient having fever less than 1 week. Now, if the patient is having fever for 1 to 3 weeks, then three important causes. Remember, typhoid is the number one cause in endemic areas in tropical countries, especially like countries in India, Pakistan, and Bangladesh. Okay, number one cause, more than 1 week. Okay, abscess, any abscesses, intra-abdominal abscesses, minimal abscesses. So 1 week you consider abscesses. Third cause is sub-acute bacterial endocarditis. Sub-acute bacterial even if you are not hearing a murmur, 2D echo should be 2D echo will reveal that there is valvular infection. Okay, sub-acute bacterial endocarditis. So these three things: typhoid, abscesses, sub-acute bacterial endocarditis are important. So in 1 to 3 weeks, more than 3 weeks is considered as pyrexia of unknown origin, and it is a separate topic which should be discussed. Okay, but just to say, the commonest causes of FUO is tuberculosis, malignancy, and connective tissue disorders. Commonest causes are tuberculosis, malignancy, and connective tissue disorders. Okay. Duration of the fever is very much important. So this is how you remember. Now, pattern and observation. So there is a pattern of fever, no, continuous fever, stepladder fever, and saddleback fever. All those are irrelevant now, because most of the patient use paracetamol, and you can't differentiate by that. But the things which are necessary, the observations which are necessary are given here. One thing is rigor. Second thing is night sweats. Third thing is relative bradycardia. So these things, the three things you should keep in your mind: relative bradycardia, rigors, and night sweats. So night sweat is actually helpful in subacute or chronic fever, not in acute fever. Acute fever, rigors and relative bradycardia. Again, rigors are only helpful. So this one is helpful in acute fever, rigors, as well as in chronic. But these two, night sweats and relative bradycardia, more than 1 week fever, these are helpful. Okay, or less than 1 week also. But you remember these three things. So if rigors are present, then it is sepsis or malaria. Rigors are present, sepsis or malaria. Okay. Night sweats are there, then it is tuberculosis or lymphoma. Tuberculosis or lymphoma. Relative bradycardia, Faget sign. What is that? Pulse is lower than expected for fever degree. Remember one thing: for every 1 degree Celsius rise in temperature, there is 10 beats per minute increase in the heart rate. For every 1 degree rise in temperature, there is 10 beats per minute increase in the heart rate. Okay, if it is not like that, then it is considered as relative bradycardia. Similarly, there is relative tachycardia, but that is not our topic here. So relative bradycardia is a sign. So if the pulse is not to the to the expectation of the degree of fever, then the causes can be typhoid fever, brucellosis, drug fever. Three things: typhoid fever, brucellosis, and drug fever. Okay, so these things you should remember. So first, documentation, then observations, and duration is the most important thing. Less than 1 week, viral infection, bacterial pneumonia, dengue, malaria, and urinary tract infection and GI infection. 1 to 3 weeks, typhoid, abscesses, and subacute bacterial endocarditis. More than 3 weeks, pyrexia of unknown origin, commonest causes, tuberculosis, malignancy, and connective tissue disorders. Observations: rigors indicate sepsis, okay, or malaria. Okay, then night sweats indicate tuberculosis or lymphoma, and relative bradycardia was seen typhoid, brucellosis, and drug fever. Okay, then now this is the same table which this is discusses the same thing. Now it is easy, no? So documentation is there. Then acute fever, so it can be viral respiratory, malaria, dengue, bacteria, UATA, and GI. Okay, subacute, typhoid, abscess. Okay, chronic more than 3, FUO. So here also same thing. Duration is the most potent discriminator for etiology. So classic fever patterns are not that helpful nowadays. But three things to remember is rigors, sepsis and malaria, night sweats, TB or lymphoma, relative bradycardia, typhoid, brucellosis, and drug fever. Okay, typhoid, brucellosis, and drug fever. Typhoid, brucellosis, and drug fever. So that's how you in history taking you will focus on these things. Okay, so one thing is over, duration is over. Okay, so some signs we have discussed, that is rigor, night sweats, and Faget sign. Exposure history is very important. Now every febrile patient must be screened for specific risk factors. So remember, there are 5 things in exposure history. Number 1, where the patient is residing, geography and travel. So tropics Tropics are nothing but those areas of the globe which are usually having high temperature. So if you go to USA or Europe or Russia, usually the temperature is low. Okay, that is not tropical area. So this area, India, China, Pakistan, Bangladesh, Middle East. So these are considered as tropical areas. Okay, so tropical areas, if there is a recent history of travel to the tropical areas, or if the patient is residing in the tropical area, you should have in your mind malaria, dengue, Zika virus, chikungunya, typhoid. Okay, how you will remember like this: viral, bacterial, in bacterial, typical and atypical, protozoal. Okay, like that you should remember. Viral, you will have dengue, Zika, chikungunya. Bacterial, typhoid. Protozoal, malaria. Like that. Okay. And if the patient is residing in USA, so this is the common thing. Coccidioidomycosis. Sorry, so difficult to pronounce. Coccidioidomycosis. Sorry. So in Southern Valley, histoplasmosis in Ohio River Valley. Ohio is a area in USA. Okay, so this is not our concern, but concern is this thing. We reside here. Okay, tropics. Okay, tropical fever, viral fever. You should remember dengue, malaria, chikungunya, Zika virus. Okay, the second thing is animal contact, vector contact. One is any human contact also. Human contact who is having the same complaint. Animal contact, vector contact, or human contact. So in that, if you should ask if they have exposure to dogs, cats, or farmers, because India is a farmer-based country, so buffaloes will be there, or so those domestic animals they will be having in their home. No, so livestock and whether they drink unpasteurized milk, that you should ask. So in dogs, leptospirosis, if there is history of exposure to dogs, the leptospirosis and rickettsia can be there in these patients. Cat exposure, cat scratch disease, Bartonella, and toxoplasmosis. Livestock or unpasteurized domestic animals, brucella is a very important diagnosis, and Q fever. Tick bites, so this one is also important. Tick bites, so Lyme disease, rickettsiosis, babesiosis, and tularemia. Just one thing you remember in mind. So the choice antibiotic for these things, for this thing is doxycycline. So these are known as zoonotic infections. Okay, zoonotic infections. And doxycycline should be in the hand if there is history of exposure to these animals or vectors. If there is human exposure, suppose he is having some respiratory infection, then we can understand that the patient may be having viral infection. So that is different thing. But animal and vector contact, doxycycline should be in your hand. Okay, just to make it easy. Then second, what is occupation hobbies? Healthcare workers are at risk for tuberculosis and viral infections. Leather and tanning workers are at risk for anthrax. Water sports or water sports like swimming. Okay, so they are at risk for leptospirosis. So that's important. Like healthcare workers, water sports, and leather and tanning workers. That's about occupation hobbies. Medical history and surgical history. Fourth one is medical surgical history. So whether the patient has implants, what is the immune status of the patient, whether the patient has HIV, diabetes, chemo, splenectomy, whether the patient is taking some medications like antibiotics, anticonvulsants, because these allopurinol, these will cause drug fever. Okay, so that is the fourth thing, medical and surgical history. The fifth thing is the high risk exposure. High risk exposure is nothing but acute HIV syndrome. You can think of syphilis, nothing but unprotected sexual or sex workers. So all those people are considered as high risk. So acute HIV syndrome you can think of, syphilis you can think of, gonococcemia you can think of, climate. Okay, these things you can think of, three things: HIV, syphilis, and gonococcemia, Neisseria gonorrhea infection. Three things, sexual history. So these are the five things, exposure history in this exposure history, which are important to obtain from patient. Okay, and usually this high risk patient will have rash or ulcer on their genitalia. Okay, important for us is this common, which we is this one. I will take it. Recent travel to the tropics, animal and vector contact, medical and surgical history. Okay, this is common things which we encounter, but you should remember sexual history also, and occupation and hobbies also you should ask. So five things we should need to ask. What are those five things? Geography and travel, tropical areas, remember tropical areas, animal and vector contact. Okay, atypical infections are common with animal exposure or vector exposure. and they present atypically also, not like normal infection. Then occupation and hobbies, medical and surgical history, then sexual history. So these are the five things. Just take a snapshot and copy and paste this picture in your mind. Okay. So the same thing in a box format. Okay, just to revise. So geography and travel, recent travel to tropics. Tropics, remember always viral. You can, how to remember? Always remember the causes of infectious fever as viral, bacterial, in bacterial, typical and atypical, protozoal. Okay, protozoal, fungal. Like this, you should remember. So viral is in tropics, influenza. Sorry, not influenza, dengue. Okay, Zika virus, chikungunya. You can think of, or some viral exanthems also. Okay, bacterial, typical bacterial fever, typhoid is the typical thing. You should remember. Okay, atypical things, zoonotic infections, zoonotics which we have discussed now, exposure to animals. Okay, rickettsia, leptospira. Okay, spirochete, actinomycetes, all these things. Protozoal, malaria is the important cause. Another one is babesiosis. This is not important. Just remember malaria. Fungal infection is common in immunocompromised patients. Fungal, you should consider candida, oral thrush, and esophageal candidiasis or something like that. So that is common, that we should keep fungal in mind when if the patient is immunocompromised. Okay, or if he is taking some immunosuppressants. So American Southwest, coccidioidomycosis. Okay, so it is a actually a parasite. Okay, Ohiorally histoplasmosis. Animal, dogs, cats, or domestic animals, or vector, tick bites. So all these are atypical. Okay, just to not to make it complicated. Okay, healthcare workers, they are at risk of TB. Okay, leather diagnosis, anthrax, water sports, leptospirosis, medical surgical history, implants, immune stasis, medications, new partners or high risk behavior, HIV, syphilis, and gonococcus. Three things you should remember in high risk patient, high risk behavior. Okay, so five things you should ask in patients high risk exposure. So that's one thing. Okay, I think the time is enough for now, and we'll continue in the next video. Thank you.